Hi, everybody. Hi, everyone. Just gonna wait till we have some people showing up. Hi there. Good evening. Thank you so much for joining us this evening. I hope that you are staying safe wherever you're calling from. My name is Lynn Hernandez, and I'm with the Desmoid Tumor Research Foundation. I'm here this afternoon to introduce you to a sarcoma specialist, a medical oncologist who has extensive experience in treating desmoid tumor patients. Before I introduce you to our special guest, we have a few reminders for you. So as you know, September is Desmoid Tumor Awareness Month, and we have 2 days left in the month. Visit our website to learn more about how you can help spread awareness for desmoid tumors. And you can also access previous Facebook Lives from this September at that web address. So dtrf.org/awareness. Also, please make sure you subscribe to our new newsletter at dtrf.org so that you can stay up to date on all of our events. Any new breaking news, you can find it all right there. Subscribe at dtrf.org. And just a reminder, I know that you're obviously watching us on Facebook right now. Remember to follow us on Instagram and Twitter at DTR Foundation. So as I mentioned before, my name is Lynn, and I'm with the Desmoid Tumor Research Foundation. I'm here this afternoon to introduce you to Dr. Candace Haddox, and she's joining us from Dana-Farber Cancer Institute. Let's say hi to Dr. Haddox.
Hey, Lynn.
Hi. It's good to see you this afternoon.
You too. Thanks for having me.
Of course, it's really our pleasure. How was your day today? I'm assuming it was pretty jam-packed.
It's been pretty busy, but I've been looking forward to this all day, so I'm happy to be here.
It's so great. It's so great. So I want to let our listeners know and our attendees know that that Dr. Haddox is a medical oncologist and sarcoma liaison to the Center for Cancer Therapeutic Innovation at Dana-Farber Cancer Institute. She is also an instructor in medicine at Harvard Medical School. And last but not least, I think her most prestigious title is she is a medical advisory board member with our foundation, DTRF. Dr. Haddox sees patients with soft tissue and bone sarcomas and tumors, and also leads clinical trials both in the sarcoma group and in Dana-Farber's early phase clinical trial program. So before we get started, I want to address a few things. Please note that this discussion is meant to provide general guidance and is not intended to provide specific medical advice on individual circumstances. If there are takeaways from today's session that are applicable to your case, please make sure you discuss them with your doctors. Due to certain compliance limitations, we won't be discussing specific drugs, including therapies in clinical trials. Clinical trials are an important option when developing a treatment plan and should be discussed with your physician. We would like to acknowledge that this educational program is made possible through a grant from Ayala Pharmaceuticals. Okay, so those are all of our disclaimers and announcements. Dr. Haddox, as mentioned, we're very excited to speak with you today as we begin to close Desmoid Tumor Awareness Month. So I want to just let everybody know we're having this conversation because Dr. Haddox has a lot of great information to share, but I really want to encourage you that if you have questions for her, she's available. Please post in the comments below, and we will get to your questions at the end of our conversation. So Dr. Haddox, let's start at the very beginning. Can you tell us, what is a desmoid tumor? Can you describe it in your own words, lay terms, and from your experience as a sarcoma specialist?
Yes, I would love to. And I would also just like to start by saying congratulations to you and the foundation and to all the participants and attendees of last week's workshop. What a great event for not just on the research front, but also for patients for those live sessions. Those were really wonderful. I enjoyed all of them myself. But to get started with your question, so desmoid tumors, these are tumors, so it's basically an abnormal growth. And under the microscope, they can resemble scar tissue. If you've ever heard of a keloid scar, that's actually what they look like. What they're actually composed of is cells that are called fibroblasts. And these are cells in our bodies that are involved in responding to wound healing issues. So at the site of a scar or a wound, you can get fibroblasts coming in. What makes a desmoid tumor is that growth is then uncontrolled. So a tumor will form, and then what we can see is on imaging, on scans, like a CT scan or an MRI, sometimes the tumor can look very well encapsulated or just like a round ball, but under the microscope, it can actually have these infiltrative borders that reach out into the surrounding tissue, and that's only apparent microscopically. So I'll pause there and see if that answers the initial question and how I might elaborate.
Yeah, so I'm hearing when you say infiltrative borders, I'm thinking tendrils, right? Kind of like that's how they're.
Yep, exactly. That is a good way to put it.
Okay. So let's talk about diagnosis. What do you recommend as first steps for desmoid tumor patients who are newly diagnosed in terms of seeking appropriate care and treatment?
Great question. I think that it's always good to start with an oncologist who's close by, to have somebody that you can reach out to if there are symptoms or questions initially. But then I also think in parallel, it's important to be seen by a sarcoma specialist or someone who sees these diseases regularly. As you know, and I'm sure many of the listeners know, desmoid tumors are quite rare. So seeing a specialist who sees these as part of their daily practice is important, because there are some nuances in management and they've changed a lot over time, as I'm sure we'll get into. So it's important to seek out a sarcoma specialist to be part of the planning and the initial treatment plan. Sometimes we'll see patients in a multidisciplinary fashion. I would say most cases actually. And will involve at minimum a surgical oncologist and a medical oncologist, at least to have the discussion around the different options that there are. So I think that multidisciplinary component is really important. And then you might also want to consider a second opinion if your first stop is at an oncologist who doesn't have expertise in this disease. You might want to reach out about a second opinion.
Okay, so when discussing treatment options, what should patients take into consideration when making this decision?
Good question. When I'm first evaluating patients, there are a couple of key things that I want to review about their case and that I also want to hear from them. And I think one thing is important to know is how are the symptoms related to the desmoid tumor? Specifically, do they have any pain? Do they have any functional limitations? Like, can they go about their usual daily activities, or does the tumor cause any impact on those activities? Because if that's the case, I'm already thinking that we need to think about treatment sooner. I also hear a lot from my younger female patients that the tumor size may fluctuate with the menstrual cycle. And additionally, they may be family planning. That may be the stage in their life that they're at. And certainly I like to be aware of any family planning, because I want to tailor my treatment recommendations around that and keep that in mind.
Yeah, it's interesting that you say this with regard to deciding treatment options and considering a lot of different things. I know that sometimes we might receive communication from patients that say, the tumor is there, my goal is just getting rid of it, right? Like that is the goal. And regardless of the symptoms,
Mm-hmm.
regardless of, is it aggressive, right? So it's really interesting how what I'm hearing you saying is, it's like, okay, well, let's look at everything. We're looking at everything. The tumor might need to be treated differently than, yeah, yes.
So one thing that I think is important to mention also is taking into account the location of the tumor. A tumor that's in an area that has room to grow, that may not cause symptoms, may not need to be treated. Whereas a tumor that's located in an area that could cause issues if it were to enlarge, even if it's not symptomatic at the time, even if it was found incidentally for another issue, maybe on a scan that was done for another reason, caught the desmoid tumor, but the patient isn't having any symptoms related to it. For those cases, if it's in a location that could become dangerous, then we also might consider treatment as well. But what we're getting at is that not every tumor needs to be treated. And I think that that is a key point, and that's something that we've learned by watching the natural history of desmoid tumors over many years. So we used to treat these tumors with therapies such as anti-inflammatory drugs or anti-hormone therapies. And the initial studies that were done, they tested those drugs in just one group of patients. There was no comparator where patients didn't receive treatment. So we would see that a subset of patients would have a good response. Their tumor would decrease in size with the therapy. It wasn't until this study was done much later, where we actually had a control group that didn't receive treatment, in other words, had a placebo. And we saw that about 20% of the tumors in the placebo group shrank down. So what that tells us is that these tumors can fluctuate. They can grow and they can regress. And just earlier this year, several Italian sarcoma centers published data showing that about 25% of tumors will initially shrink. And of the ones that initially enlarged, almost half of those will go on to shrink. After having this initial, enlargement, they'll go on to shrink, some of them shrinking significantly. So that really justifies, in the right context, watching and waiting and seeing if the tumor regresses on its own. Now, going back to what I said earlier, if a patient is having symptoms related to the tumor, or if it's in a critical location where we would be concerned about any growth, then that might push us to consider treatment sooner.
Mm-hmm. Mm-hmm. Yeah, that's it's such a complicated thing. I'm glad that you mentioned that study as well. And it was very, very interesting and surprising to read, to learn, right?
Definitely.
Okay, so, if a patient is going in for a consultation with their physician, what questions do you recommend they ask?
I think that the first question is really, do they have experience treating the disease? And I can see how that might be uncomfortable to ask of a physician, but I would start by asking it maybe as like, I've heard that desmoid tumors are rare. Is this something that you see a lot of? And I think that that would prompt the physician to say more about their experience with the tumor. I think that it's important to ask about the pathology review. So the diagnosis, it can be straightforward, especially in the right context, meaning if it's a typical location that a desmoid tumor tends to arise, or if there are certain features under the microscope, it might be very straightforward, but sometimes there are some tricky cases. And I think it doesn't hurt to have the pathology, the diagnosis reviewed by an experienced pathologist. I think it's important to ask about all the treatment options. So there may be one that a physician is leaning towards, and they may focus on that, but I would ask them to be more broad and say, broad, let's start back at the 10,000 foot view. And how do we generally approach these diseases? What is unique about my case that makes you want to recommend this treatment over that treatment? And I think that as a general rule, you should leave feeling like you understand the plan and you feel comfortable with the plan. And I think out of haste, we sometimes gloss over some details or just use jargon and things like that. But make sure that you understand. Don't be concerned about asking questions. And this is your journey. And I can't emphasize enough how important it is that you feel comfortable with the plan.
Mm-hmm. Yeah, I'm really hearing that. And I think that, it doesn't hurt to really, put your doctor's feet to the fire, right? Like they're working for you. And that feels really important.
And I think that they're a partner too. Like you feeling better makes your doctor happy too. Mm-hmm. So we all have the same mission and the same goal in mind. And that's to do the best thing for the patient. So there should be no hard feelings about, really making sure that you have a good understanding of the treatment plan. The other thing I meant to mention here is that it's so important to consider the mental health piece. I think, a lot of times in my consultations with patients, we're talking about, their general health, right? Because that's important too. We're talking about their desmoid tumor and what symptoms they might have. And we're talking about the natural history of desmoid tumors and how they typically behave. And then I talk about the different treatment options and we talk about, their preferences and things like that. And time goes by very quickly. And one piece that I think is often left out is about, if we're on this strategy of, there's a tumor in place, we're going to watch it and wait and may not start treatment. And what we're getting is that this can be a long-term disease that the patient has to live with. And psychologically, I want to acknowledge that is challenging. One of my patients described it as he felt like his body had betrayed him in a way. And that just really made me think about psychologically how difficult it is to have a chronic disease like this. Mm-hmm. So I'll reference back to the DTRF interview, I think about a week ago with Ashley Williams, who's a clinical social worker. She gave such a great overview of tips for managing stress, not just long-term, but also in those really triggering situations, like when you're in the doctor's office waiting in the waiting room, or when you're waiting for your scan, or gosh, the radiology reports now show up in our patient portals and we can see the results before we even meet with the doctor. So, mm-hmm. All of that can trigger so much stress. So it's so important to consider that piece as well. And seek out things like social work that can really be great partners in caring for the patient and really helping to manage that psychological piece.
Yeah, I'm really glad that you brought that up because Ashley, and I'm not sure if you're aware of this, but she does a series with us called Dealing with Desmoids. And she and I get together once a month. We have a webinar. It's not a conversation. It's kind of a presentation that she does via webinar format. And she tackles these different topics. And just for patients that are joining us right now, if you go to dtrf.org/dealing with desmoids, no spaces, you can access. We have, I think, 4 sessions posted already, and we actually just finalized the date for our next one, which is November 15th at 7 p.m. We will begin publicizing that. But yes, Dr. Haddox, I really appreciate that. That's a huge, very, very important component. Very important component. Okay, so I have another question for you. How often should desmoid tumor patients get imaging done of their tumors?
That's a good question, and I would say it's a little challenging because there's not like one recommendation that fits all. So in the guidelines, every 3 to 6 months is appropriate. But I think for patients that are on this observation trajectory and maybe they've had recent symptoms, but they want to observe a little bit longer, they feel comfortable with that, but we want to keep a close eye on the tumor. Sometimes I'll lean towards the earlier part of that 3 to 6 month range. But for my patients who are doing really well, I'll sometimes even push it out to 12 months. I think it just depends on the behavior of the tumor and how it's declared itself so far, whether the patient's on treatment or not, whether they're having changes in their symptoms. I think anytime that there are changes in the symptoms, or if the patient feels like the tumor is getting larger, if they can feel it, if it's in an area of the body that they can feel themselves, that would prompt earlier imaging. Or if it's in a more critical location, like those tumors that are within the abdomen and the tissue that's called the mesentery, those I tend to watch a little bit closer as well.
There's a lot of important structures in that area.
Yeah.
Yeah, yeah. Okay, so let's talk about second opinions. This topic comes up often in our community, and I know we talked about it a little bit before. What are your thoughts on getting second opinions and how to go about doing it? And how does a patient know if they need one?
That's a good question. So I would say that if you are at a center that doesn't have expertise in this disease, then it is very reasonable. I would strongly encourage a second opinion, just to make sure that the management plan is sound and to develop a partnership between the oncologist who you might stay with and a sarcoma specialist. Sometimes because we're kind of scattered across the country, there may not be one like in your backyard. So if that's the case, then it's okay to stick with a local oncologist for follow-up and things like that, and questions or symptoms. But I would at least have a sarcoma specialist or a desmoid tumor specialist in the mix. So that's one point about should you get one or not. Then the next thing is, I think, if there is a plan to do something aggressive, something meaning a big surgery, a potentially debilitating surgery, or starting a medication in the absence of symptoms, or if the tumor is not in a critical area, or even just for your own comfort. I think in those situations, it is best to get a second opinion. I can see it in my patients' eyes that a lot of them feel bad about seeking out a second opinion. And I see a lot of patients who, I feel privileged that I'm kind of in their backyard, but some of my patients travel from far to see me as a second opinion. I can see that there is this tension or worry about what their local oncologist might think that they came to see me, but it is not like this. We are colleagues. I share a lot of patients with a lot of colleagues. I think one good way to ask your doctor about seeing a second opinion is to ask them if there's anyone that they would recommend, just to hear from a specialist. And I don't think that any doctor would push back on that. And honestly, shame on us if we would. It's like I said earlier, it's your journey. You have to feel comfortable with the plan and feel like you have a good understanding and explore all options. And if you get the same answer at 2 different places, then that's great. But I think that it's important to explore if you feel like uneasy about anything. Does that Does that make sense, Lynn?
Yeah, it absolutely does. And I really appreciated what you said about, if it seems like the doctor is suggesting something radical, right? It would be really helpful to have another doctor co-sign that versus feeling maybe unsure or, you know,
Mhm.
I mean, if it feels radical, that makes a lot of sense. When you and I spoke earlier, we talked a little bit about getting a second opinion on pathology reports.
Mhm.
Can you speak to that a little bit?
Yes. So like I said, I think in a lot of cases, desmoid tumors are pretty straightforward to diagnose under the microscope. But if there's any question about the diagnosis, then having it reviewed by a specialist is important. I know our pathologists here at Dana-Farber see a lot of outside cases that they review to make sure that the diagnosis is correct. So not every patient has to physically come here. Just the tumor specimen, the biopsy that was done, or if the tumor actually was removed, they're always stored at the site that the biopsy or the surgery is done at. So that pathology department has the tissue and they store it. And then if a consultation is requested to have that pathology reviewed, they just send over some slides or some of the tissue for the pathologists that are consulting on it to review. And that is typically coordinated between the two pathology departments. The way that it works for us is our administrative teams can help with that logistically. So really, it just has to be mentioned to the doctor if that's initiated by the patient. Just ask them to have it reviewed outside. Sometimes pathologists will consult amongst themselves, so they'll like automatically request that another physician or specialist weigh in to confirm the diagnosis if there's any doubt or if there are some atypical features or something like that. So sometimes that can happen even behind the scenes. But if it's initiated by the patient, the treating oncologist or the oncologist who maybe requested the biopsy, anyway, they should be able to coordinate that second opinion on the pathology.
Okay. Okay. Okay, so next question. So how do you suggest patients approach a second opinion? I think that, and we talked a little bit about this, that some people can feel awkward about requesting it, almost like there might be like a lack of trust there. I feel like you already talked about this a little bit.
Yeah, no, it's okay. It's such an important question, and just to I think that this example will really help patients and the listeners feel comfortable about requesting a second opinion. And that's one of my colleagues who's a surgeon. If he's planning a really aggressive surgery, he doesn't just operate on desmoid tumors, but we also treat sarcomas. But if the plan is for a really aggressive surgery, he requests that the patient go seek a second opinion. So even amongst us, like we are in as a desmoid tumor specialist, a sarcoma specialist, other sarcoma desmoid tumor specialists, we even refer patients to each other. And there's no bad feelings about it. So I just want to, again, state really clearly, you should feel comfortable talking to your doctor about it and letting them know, and they should also be supportive of it.
Mhm.
And if so, I would just say in your visit with your doctor, if this is something that you would want to pursue, I would just say something like, I would like to get a second opinion just to hear another perspective. And I think that that's all you would need to say. And then they could ask follow-up questions. They'll probably say, is there somewhere that you're interested in seeking a second opinion at? And then they can, specifically refer, or they may, like I said earlier, they may have somebody in mind that they've worked closely with or trust, and you can ask your doctor to reach out to them. So I would say that's one way to go about it. The other mechanism, which is becoming more, I think, utilized recently, is an online second opinion. And really, if you just search online second opinion, and then I would search, I think desmoid tumor probably wouldn't come up as easily as searching cancer. And Lynn, let's not forget to distinguish cancer and desmoid tumors later. But if you just search that phrase, you will see a number of options. Usually the larger cancer centers will have this as an option to seek a second opinion online. And then they work with you to get records and even images. Some of them will include like your actual images from your scans, not just the report, but the actual images. So lots of information that the consulting doctor can review. And the only thing that I think can be tricky is some of them are covered by insurance or the health plan, and some of them are out of pocket, and they can be kind of pricey. So that's the only caveat there.
Okay. This is a good start, though, for people that are thinking about it. So next question, besides tumor growth, what are some signs that it's time to explore a different treatment? What are your thoughts on how patients should approach results like stable tumor, or improved pain when the tumors themselves are not shrinking?
That is such a great question. So I have seen with a lot of treatments that the tumor may not shrink, but within a month or two, the patient is already feeling much better. And we don't see the effect of the medication may be minimal. Like we may see almost no shrinkage or stable, but the patients feel better. And some of them have told me that their tumor, like the texture or hardness of it, feels softer. So in that case, I think it's plausible that maybe whatever effect it's having on the nerve fibers that are triggering those pain signals is lessened. So I do think that patients can feel better with some treatments if they're having symptoms even before we see changes on the scans.
Okay. Thank you for that. So I have one other question for you, and then we have quite a few other questions that have come in. And I know that you saw this last year. We hosted a live event specifically about desmoid tumors and the term cancer. We just kind of spoke about this.
Yes.
As you're aware, this is a frequent topic of the community. Some patients, as you know, feel that this disease should be categorized as a cancer because what they go through is sometimes similar to metastatic cancer patients. They feel that their friends and family would take their illness more seriously and give them more support if it were categorized this way. Others feel desmoid tumors are something entirely different in a class all their own. Either way, the word benign can be very misleading, especially for newly diagnosed patients. Can you share your thoughts on this?
Yes, definitely. This is definitely a theme that I hear from my patients a lot too. So technically speaking, the difference between a tumor or a growth and a cancer is that cancers can spread to other parts of the body that are far from where they started. A tumor is just an abnormal growth. However, that doesn't mean that it doesn't cause problems. And I think that that's the misleading thing about calling it benign, is that benign implies that it's nothing to worry about. It's not going to cause any issues. But in reality, we monitor these just like we would a true cancer. We treat them with agents that we use to treat cancer. They can absolutely cause symptoms, complications, and in rare, although few cases, they can be life-threatening. And I think for all of those reasons, it's a serious disease. And I try to make that clear to my patients when I meet them for the first time, because I do think that patients feel that this disease isn't taken as seriously as a cancer, but for all those reasons that I just mentioned, it can be serious. And I hope that helps to clear it up a little bit.
Yeah, absolutely. I mean, I know, I feel like whenever we have a doctor that really is able to like acknowledge that nuance and acknowledge how challenging it is, I think I'm making up that it's validating for the community, which feels really important. Um, so let's move on to some questions.
Okay.
Okay. We're going to kind of go backwards a little bit. So we're going back to we were talking about the Italian study. You were talking a little bit about that. How far along, and I don't know, I'm not even sure if you can speak to this, but I'm going to throw it out. How far along is the research that will help figure out why they grow or regress?
I love that question. That is a very good question. I really think that our efforts need to be directed at that question. I don't have a good answer now. I would say that in the past, I think I mentioned, it was thought that there were hormonal influences to desmoid tumors, that, as I mentioned, some women have reported that the tumor is enlarged during menstruation. They have been shown to enlarge during pregnancy. So there was this hypothesis, this idea that desmoid tumors are driven by hormone signals. But I think that that relationship is not as clear, actually. And I know that we just saw some data that was presented last weekend from the awesome study that the DTRF is doing on pregnancy-associated desmoid tumors. And by the way, if you haven't seen that session, the DTRF is actually getting survey feedback from patients that have pregnancy-associated desmoid tumors. And I think those data are critical for us to understand more about this. But getting back to the question, it is not very clear, the linkage with the hormones. And in fact, what that study has shown so far is that the tumors basically maintained their behavior during pregnancy and after pregnancy. So if it was growing before pregnancy, it was growing after pregnancy. If it was stable before, it was stable after, etc. I've certainly seen patients who have had growth of the tumor after pregnancy. It kind of makes me think that this disease affects young women, and in that population, we can expect to see that those who are pregnant may have some growth, may have stabilization, may have a decreased size, but the relationship isn't clear and the causality isn't clear. So I look forward to seeing the research that will be ongoing on this question. I think it would be really fascinating to explore if it's stress related, if it's diet related, if there's some inflammatory factor, if there's an infectious factor. All of these are unanswered questions. They're challenging to study, but I think that they're important questions. And I hope that we can answer this question to help us understand more about this disease. And if we understood those factors more, maybe we could understand how to drive a tumor to regress that is growing, or to target the pathways that may be involved in causing that tumor to grow and then induce a regression. So I think those are really powerful pieces of information that we still need to uncover, but is on all of our minds.
Okay, okay, thank you. Um, so one of our other viewers is asking, when a tumor regresses spontaneously, can it grow again?
That's a good question, and I would say that yes, it can grow again. So there are some things, even though we don't know what factors specifically might be at play when the tumor does start to grow again, there are some hints on imaging. And we talked about scans earlier, Lynn. One of the things that's been interesting that's still, I would say, in the research space is MRI, and how some of the signals that we can detect with the MRI scanner can show us more active areas in the tumor, and that can be predictive in some cases. So if depending on the location, that is something that I like to consider, is getting an MRI. That helps me kind of track the activity a little bit better. And we can also see that activity changes with treatment if the treatment is effective. So MRI can be kind of powerful for predicting those changes.
Okay, okay. So next question. Do extremity tumors respond better to certain treatments than mesenteric tumors, or does it vary based on tumor instead of location? Do you want me to read that again?
No, I think I that's a great question. I think I understand. And I would say that our studies don't really show that the location in terms of treatment matters as much, but I want to carefully choose my words here, because there are some times where I'll consider one treatment over another because of the location. For example, for tumors that are located in the mesentery, which is the fatty layer that brings the blood supply to and from the intestine. For those tumors in that location, which if they get larger, can actually fuse with the bowel, or could disrupt the movement of the bowel. And those I worry about patients getting blockages or obstructions. So those I'll consider treatment. But some of our treatments we've seen in clinical trials have led to complications where maybe we see fusions between the tumor and the bowel, which may or may not be related to the desmoid tumor. Just the drugs that we've used for other diseases and stuff, we know that they can cause issues with wound healing, and we think that that can drive this complication. So that might push me to choose one treatment over another. So I think that location is important in choosing treatment, but we don't see that one tends to respond better. Does that make sense?
It does. It does. It makes me think of our consensus paper. And
Exactly.
now the consensus paper is pretty general, right? Like as far as like medical treatments. It doesn't say, this drug versus this drug. And that's what I feel like I might be hearing you say a little bit, right? Is that you're distinguishing maybe between different kinds of medical treatment. Whereas
Right.
the consensus paper is saying surgery versus medical versus whatever.
Mm.
But yeah, and we actually just posted in the comments below a link to the consensus paper, and we strongly encourage that that patients and care partners check that out. And I'm not sure if you're aware, Dr. Haddox, but there is going to be a meeting in 2023. I believe it's June, to start working on the next version of the consensus paper, which is very exciting.
Yes, and it's great that that will incorporate some of the more recent advancements that we heard about last weekend. So that's really exciting.
All right, so next up, are there statistics showing the number of people that have had their tumor removed and had it not grow back?
That's a good question. We generally quote about 50-50. But I think that it does depend on a number of factors. I think that it's maybe more straightforward to not being a surgeon, I should make that disclaimer. It is more straightforward to remove a tumor that is in an area that doesn't have a lot of blood supply around it, or nerves that you have to work around, or other critical organs. So removing those tumors are going to be more straightforward than removing a tumor that's sitting right up against a blood supply or something like that. So I think that's important to take into consideration when we're thinking about recurrence risk.
Okay, so next up, would you recommend a CT or MRI scan for a mesenteric desmoid? This viewer says a radiologist told me that a CT may be easier to read.
That's a great question. I love this question. So I mentioned MRI earlier, and I do think that in general, desmoid tumors can be evaluated really well on an MRI, and it gives you that additional signal that can indicate more activity within the tumor. but it is tricky in the mesentery. And the reason why is if anyone has had an MRI, you know that it's a long scan. It's like being in the scanner for 45 minutes, whereas the CT scan is like, zoop, you just move through the donut and you're out. And with that longer scan time, think about the intestines are constantly moving. You're probably aware of this, just, getting on dinner time if you're on the so with the intestines moving a lot, that can create some artifact on the MRI because it's a longer exposure. Thinking about like taking a picture of somebody that's moving, it's blurry. So that can make a challenge. So in some cases, it is easier to see on CT scan. But I've also seen some desmoid tumors in the mesentery just look more diffuse. Like I've certainly seen, like I described earlier, these really well encapsulated ones that just look like a little ball. But then I've also seen ones that are more subtle and diffuse. And it is a good question to talk about with the oncologist. And then they talk to the radiologist to come up with a plan on what the best imaging scan is to do so that they can best evaluate the desmoid tumor.
Oh, that's great. It makes a lot of sense. Okay, so we have our next question. What is the recurrence rate when cryoablation is performed? This patient says that they have 2 tumors. One is inferior to my large abdominal wall. And then one was treated with cryo.
Mm-hmm. So cryoablation, I'll just say for everyone listening, in case you've never heard of this before, it's basically a way to freeze the tumor from the inside out. And little ice crystals actually develop within the tumor, and that shatters the cell, the membrane, the outer rim of the cell, and it just kills the cells. So this technology has been emerging and it's been studied in desmoid tumors in a small study. So we are doing this and we are getting more experience with it over time. The data aren't very mature in that, like, we don't have a lot of data that's published on it. But the control rate of the tumor is really good. So we can often see that the tumors shrink, or we'll see changes in the MRI characteristics or the CT scan characteristics. And sometimes the tumor will be quiet indefinitely. Sometimes they do come back and start to sort of reawaken and regrow. It's sort of a time-dependent thing. The study that was done, I want to say that they looked a couple years after the patients were on study, and a lot of them were still doing well at the time that they collected the data, but we don't have great long-term data on how well that approach sticks and keeps the tumor under control for long-term.
Okay. Okay. So we have our next question. Our viewer says, my oncologist says that it's hard to decide on treatment because my tumor is not growing. I'm working with a multidisciplinary team to strategize and manage pain. Is there anything I can do to help my oncologist make a decision on treatment?
Ooh, that's a tough question. So I would say this is, going back to your question earlier, Lynn, about when is it a good time to get a second opinion. I think when you feel like you're having persistent symptoms or the current treatment isn't working or something like that, that's a good time to seek out a second opinion. I think sometimes we don't always have the data that we would like to say treatment X is better than treatment Y. And as sarcoma specialists and desmoid tumor specialists, we kind of deal with this a lot, where we have a lot of trials that are exploring individual therapies, but they're not comparative. They're not comparing this one versus this one. So it does make it tough sometimes to weigh, whether treatment X or treatment Y is better. So sometimes what it boils down to is things like the anticipated side effects of the medicines that are being discussed. Sometimes the convenience of the treatment. Some treatments are given IV. Some treatments are a pill that is taken daily. So I think some of those convenience factors are important to consider. Sometimes general health is also important to consider. And I have no doubt that the doctor has kind of weighed all of these, and it sounds like there are a couple of options that would be good options. And then it's kind of the patient's comfort too, with after hearing about all the side effects and the treatment schedule and those sorts of things. What do they feel the most comfortable with too? I think that that's an important piece to put in the equation when deciding therapies. But if it doesn't seem like there's a good resolution, I think that that's a good time to get a second opinion or to consider a clinical trial if that's available, or something like that.
Okay. Okay. We have another viewer asks, I've always been curious if I've always been curious if I also have FAP along with my desmoid tumor. What's the best approach in finding this out? And would I know if how would I know it if I had it as far as symptoms go?
Oh, that is a good question. And I feel bad that we haven't addressed FAP yet, and it's 50 minutes into us chatting. So I should mention that FAP is about 2 to 5% of patients with desmoid tumors will have FAP. And what FAP is it's a familial polyposis syndrome. What that means is that the patient may have innumerable polyps. So sometimes the inside of the colon will actually look like cobblestone. There can be that many polyps, like so many that you can't count. And that puts the patient at high risk of developing colon cancer. So that's typically in patients who have FAP, they often have other family members where there's a signal that, there's colon cancer in the medical history, particularly earlier diagnoses of colon cancer. That would raise concern for me. But I've also treated patients where they were the first case of FAP in their family. Mm-hmm. Because sometimes you inherit, basically the way that FAP works is there's a gene called APC. Everybody has 2 copies of that gene. One you inherit from your mom, one you inherit from your dad. So everybody has 2 copies, and also 2 copies to pass on if you have any children. But anyways, if one of those copies has a mutation in the gene, that's what causes FAP. So sometimes that mutation can be passed down, from the parents, but sometimes it can arise just spontaneously. But it could also be passed down to their children. Does that make sense? So there can be just an initial case of FAP in a family. So we don't always have to have this background of family history of colon cancer to have FAP. The other thing that I'll say is FAP can be attenuated, meaning that that there are about 100 polyps. So still a lot of polyps, but not like innumerable polyps. And usually those patients may develop colon cancer later in their lives. And then that doesn't always send up the red flags that there could be FAP or a mutation in the APC gene going on. But those patients might also develop desmoid tumors. So not everybody with FAP will develop a desmoid tumor, but it is an increased risk because that mutation in APC ultimately causes beta-catenin signaling. If you look at your pathology report, you might see in there that there's beta-catenin staining, and that's a marker of the desmoid tumor. So they are definitely linked. And it's, like I said, about 2 to 5% of cases. There are variants, other genes that could be involved in causing a polyposis syndrome as well as desmoid tumors, but those are quite rare. At the end of the day, I think it's a good idea to do the testing. I always offer it to my patients at some point early on in our meetings, at least so that we're thinking about it. And it would certainly have implications for them and their cancer surveillance. but also might have implications for their family. So it's an important discussion to have. The way that the testing is done is they can do a blood test or a cheek swab and just look for the APC or other genes that might cause FAP. They can look for those mutations within those cells in order to make the diagnosis. So that's often done through genetics counseling. They could do the testing on the tumor itself as well. So that's also an option. Sometimes I'll send off that test. If my suspicion is low that the person has FAP, sometimes I'll do the testing on the tumor itself. But otherwise, I usually will refer my patients to a genetics counselor to have that detailed discussion on whether to do the testing, what the family history looks like, to get counseling on what to do with the information once it's received.
Mm-hmm.
I think that is a really personal decision about whether you would want to pursue a genetic testing to identify a condition that could increase the risk of cancer, and how to share that with family members and all those factors. So that was a long-winded answer, but I think it's important that we had just a little more comprehensive discussion on FAP.
Yeah, no, that was wonderful. So a patient is asking, if I have a desmoid tumor and someone in my family had colon cancer, should I get tested for FAP?
I think that's very reasonable. I think that is very reasonable to do that testing.
Okay.
I think that there are some specifics about, how close is the relationship? Is it like a parent or a sibling, or is it, a few degrees away, a second cousin or something like that? I think changes the risk a bit, or changes the likelihood a bit. But definitely, I think if there's any question, or just for that reassurance, it's very reasonable to do the testing, and it's pretty straightforward too.
Okay. Okay, this is really helpful. I think that we're finished with our Q&A right now. Thank you, everyone, for your questions. These are great questions. Dr. Haddox, another question for you from us. Are you currently seeing new patients at Dana-Farber?
Yes, I am. I'm definitely seeing new patients, and always happy to meet with a patient with a desmoid tumor and kind of go through the steps that we already discussed, and have a good conversation about their disease and what treatment looks like. I also work with a lot of colleagues here who have expertise in desmoid tumors, so we're definitely accepting new patients.
Oh, that's great. I'm sure that some people are very excited to hear that. So this was wonderful. Thank you so much. This was amazing. I really hope that we get to do this again at some point.
Definitely.
I feel like I learned a lot, and I'm sure that I'm speaking on behalf of the community as well, that we really appreciate your time and your service, and we're thrilled that you're on our medical advisory board.
I'm thrilled too, and don't mention it. This was great. I love chatting with you, and I love just interacting with the community and the foundation in general. So let's definitely do it again.
It sounds great. Well, listen, I'm going to say goodnight to you, and then I have a couple other announcements for the community. So I hope you have a great evening, and we will definitely be in touch.
Sounds good. You too, Lynn. Bye, everybody.
Okay. Bye-bye, Dr. Haddox. Okay, so I just have a few more things that I wanted to share with you guys before we close, and I'm repeating myself here, but we're still in September. This is your month, Desmoid Tumor Awareness Month. Make sure to visit our website to learn how you can continue to spread awareness. And also, if you would like to view Facebook Lives from earlier this September and actually last September as well, you can go to DTRF.org/awareness. So make sure that you visit that page. And if you go to our Facebook page, you'll be able to see at the very, very top will be the recording after we finish today. So feel free to share that. Just a reminder to please make sure that you subscribe to our newsletter if you haven't already. This way you can make sure that you're staying up to date on events and news, etc. We encourage you to sign up. And then just a reminder too, I know that obviously you're following us on Facebook right now, but make sure that you also follow us on Instagram and on Twitter at DTRF, DTR Foundation. We have a lot of great, exciting things that we're going to be sharing during the rest of the year and during 2023. We're on high momentum and we're excited about that. So I think that's pretty much all. Again, we would like to acknowledge that this educational program is made possible through a grant from ILA Pharmaceuticals. We're grateful for their support. And then I finally wanted to thank our producer, Amanda Hoffman, who's done a phenomenal job. Thank you again to Dr. Haddox, and we wish everyone a good night. Thanks so much for joining us. Bye-bye, everybody. Have a great night.